Hey, good morning, and thank you for having me. My name is Jennifer Carrano, and I'm an assistant professor in the Department of Human Development and Family Sciences at the University of Delaware. And much of my research focuses on examining various aspects of substance abuse disorders. And today I'm going to talk briefly about one of my projects, which has been generously funded through one of Excel's pilot grants. And this study is really focused on examining substance use disorder recovery among individuals who are living in recovery residences. Figure out how to move my slides here. There we go. And just to give you a little bit of background, so substance use disorders, or SUDs, are really considered by many to be the leading public health problem in the U.S. And this is in large part because they lead to more illnesses, disabilities, and deaths than any other modifiable health condition. And this really is a growing problem. We know that in 2017, more than 70,000 Americans died from drug overdoses. And this is a number that's quadrupled in the last 2 decades. And in addition to that, costs to society are really staggering, with the U.S. spending more than $740 billion annually on SUD-related costs. And this is also a problem that's widespread, with more than 20 million Americans meeting criteria for SUDs, very few of whom ever receive treatment. And even among those who do get help, it's typically in the form of relatively short or acute treatment. So this includes things like medically assisted detox and time-limited inpatient programs, which typically last anywhere from 21 to 90 days. And importantly, what we know is that relapse rates following these types of acute treatment are estimated to be somewhere between 40 and 90%. And relapse is most common in the initial days and weeks following acute treatment, when there's this noticeable gap in what we think of as the continuum of SUD care. Because often what happens is that following discharge, people return to environments that previously promoted their SUDs, and they often have few resources in place to help them maintain their recovery. So if you think about it, you can imagine that it's relatively easy to maintain your sobriety when you're in an inpatient facility and away from the daily stressors of everyday life. And you also have restricted access to drugs and alcohol, but this obviously becomes much more difficult when people return to the community. And so this really indicates a need for long-term community-based services that can help people make the transition from acute treatment to long-term recovery in the community. And so one community-based treatment option that appears promising is recovery residences. And this is really just a broad term that encompasses any type of residential community where people in recovery from SUDs live together in a substance-free environment. And we know that there are currently thousands of these homes operating in the U.S., but there's huge disparity and variation in regards to things like what types of services they offer, the policies they have in place, and the support staff that's available to residents. And importantly, there's also been very limited research on their effectiveness. So to date, only 3 groups of homes have been studied. Results from these studies do suggest that there may be a number of positive outcomes in terms of things like decreased substance use, gains in income, decreases in psychiatric symptoms, and decreased criminal activity. What we don't know, however, is whether these gains apply to other types of RRs, and we don't have good evidence telling us how these homes might promote these positive outcomes. And so we think that their effectiveness may actually be due to increases in recovery capital for the residents who live in these RRs. And so by recovery capital, I'm referring to the economic, social, and psychological resources that really help reduce the risk of relapse. And so for our study, we developed this conceptual model that outlines the process by which we think that RRs lead to positive outcomes. And basically what we're positing is that specific characteristics of individual RRs, so things like what types of services they offer, what types of policies they have in place, all work to increase recovery capital. So this is things like financial well-being, social support, and psychological well-being. And in turn, it's this recovery capital that leads to long-term recovery. And importantly, we do recognize that individual level factors may moderate this process. So things like somebody's socio-demographic background, their substance use background, so treatment and relapse history, and also other things like experiences of trauma or comorbid mental health conditions. And so really the overall goal of our project is to test this conceptual model. And so specifically, we're looking at these 2 research questions. So first, how does recovery capital, so again, the financial well-being, perceived stress, social support, and internalized stigma, change as a function of the amount of time spent in recovery residences? And also, what specific individual and RR level characteristics predict this change? And second, we want to be able to identify specific profiles of individuals for whom RRs are most likely to predict recovery. And so we're doing this by following a sample of 100 residents who are drawn from 8 different RRs in Delaware. And we're following them monthly for 10 months, so both while they live in the RRs and after they move out. And so each month they're being asked to fill out a self-report survey that measures their substance use behaviors, various indicators of recovery capital, and also their individual characteristics. And so for the sake of time, I'm not really going to go into depth regarding the analytic plan, but basically we're planning on using HLM models and random forest analyses to answer these questions. And so the results of these analyses are going to tell us a number of things. So first, we're going to be able to look at whether RRs are effective in promoting recovery capital and also SUD recovery. Second, we'll be able to identify specific characteristics of RRs that most strongly predict gains in both recovery capital and long-term recovery. And finally, we'll be able to identify these specific profiles of people who are most likely to benefit from staying in these RRs. And this last piece is actually pretty important because what we know is that there currently aren't enough beds available for everybody who needs them. And so the staff in these homes are often forced to make really difficult decisions about who to admit. So this is a way to help them better target what really are limited services. And so in the end, we hope that the results will inform both practice and policy. So for example, results might help the RRs improve or add different services and policies. And additionally, if we do find evidence of effectiveness, there's really a case to be made for increased public funding for this type of service. And so we just started data collection last month, and so far we've managed to enroll 60 out of our targeted 100 participants. So I think we're off to a pretty good start, and I'm really looking forward to seeing how things progress in the coming year. And I just want to end by thanking my collaborators, both at UD and at Christiana Hospital, and also our community partners, so Lyman House and Attack Addiction, who have given us, both feedback on study design and also given us access to their RR so that we're able to complete this work. And I'm going to end here and thank you very much, and I'm going to open it up for questions.